Thank you, and welcome everyone to today's webinar. Today is our fourth webinar in our Long-Term Care Plus Acting on Pandemic Learning Together. And this is our fourth webinar in our series entitled Next Steps in COVID-19 Care in Response to Long-Term Care and Retirement Homes. So today's focus is on people in the workforce. So I'd just like to say that I will be moderating this session from my home office in Ottawa, Ontario. I would like to acknowledge that my home office in Ottawa is on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. So today we have a host of panelists who will be presenting today. So we have Deba Hafizi, who is a Knowledge Mobilization Officer at CADDIS with a background in public health from Queen's University. She has previously worked in multiple clinical research settings and utilizes these skills to translate evidence into informed decision-making in her role at CADDIS. Dr. Leslie Weisenfeld is the Chief of Psychiatry for Sinai Health, an academic health science center in Toronto. Dr. Weisenfeld is a geriatric psychiatrist and the physician lead for the Interprofessional Geriatric Psychiatry Consultation Liaison Service at Mount Sinai Hospital, which provides psychiatric care to older patients admitted to the medical and surgical floors. Together with colleagues, Dr. Weisenfeld has participated in developing resilience coaching for staff at Sinai Health and is part of a multidisciplinary team providing support to vulnerable nursing home partners during the pandemic. Our objectives for today are to learn more from CADDIS and Sinai Health's work related to people in the workforce during the pandemic, to offer concrete strategies for organizations to support and protect people in the workforce, and to share program updates and next steps to participate in the Long-Term Care Plus Acting on Pandemic Learning Together. So this program is based on a report that we published back in July 2020 entitled Reimagining Care for Older Adults. This report was based on over 40 interviews with family partners in care, healthcare leaders, and policymakers across the country, collating their experiences from their pandemic response in the spring of 2020. It focuses on 6 promising practices in 6 key areas that have the potential to reduce the risk of future COVID-19 outbreaks or mitigate their effects. These 6 key promising areas include preparation, prevention, people in the workforce, which will be the focus of our discussion today, pandemic response and surge capacity, planning for COVID-19 and non-COVID-19 care, and presence of family. So just as a reminder, the people in the workforce component of the 6 promising practices focuses on strategies to stabilize and reinforce staffing within the long-term care and retirement home sector, addresses working conditions and psychological health and safety of the workforce, limiting staff to working in only one high-risk environment with supports to make that possible, training to increase capacity of the workforce, which we are mostly seeing related to infection prevention control practices, recruitment of additional staff to help stabilize the workforce and act as a surge capacity, and awareness around community transmission risks and information on how to mitigate where possible. And we are very grateful to be offering this program in partnership with many partners across the country, including the Canadian Patient Safety Institute, with whom we have published this report back in July, the New Brunswick Association of Nursing Homes, the Canadian Agency for Drugs and Technology and Health, and the CMA Foundation. I will now pass over the presentation to Deba, who will speak about evidence on best practices for supporting staff and mitigating concerns during reopening of long-term care homes.
Thank you so much, Tanya. So, hi everyone, my name is Deba, and on behalf of CADDIS, I will be presenting a snapshot on the evidence of best practices to support long-term care staff and mitigate their concerns during the pandemic and reopening processes. Next slide. So first, just a bit of background on CADDIS. We are an independent and not-for-profit organization that delivers objective evidence to Canada's healthcare decision makers. Next slide. So essentially what we do is deliver evidence, analyses, advice, and recommendations to inform a broad spectrum of needs, typically related to the optimal use of drugs and medical devices. Next slide. So We're funded by the federal, provincial, and territorial ministries of health, with the exception of Quebec, and just 2 of our programs being C4 Service, that is the CADDIS Drug Decision Program, and the CADDIS Scientific Advice. Next slide. So jumping into today's topic, CADDIS was asked to review the evidence on best practices to support long-term care workers and mitigate their concerns during reopening processes in the context of the COVID-19 pandemic. We conducted a limited literature search for clinical evidence published between January 2014 and July 31st of 2020, whereby recent and relevant Canadian sources were prioritized. Given the nature of the evidence found and the evolution of the pandemic on long-term care policies, the focus was shifted to broader information on how to support LTC staff throughout the pandemic and not solely during reopening of homes to families and essential visitors. Next slide. So I just wanted to acknowledge that the summary of evidence was prepared by CADDIS Implementation Support and Knowledge Mobilization Team, as well as the Research Information Specialist Team. There were no disclosures or conflicts of interest to declare while conducting this review. Next slide. So overall, 14 pieces of evidence were identified, which ranged from observational studies, rapid reviews, guidelines, government guidance, special reports, as well as web and news articles relevant to the topic. 4 resources fell under the category of safety concerns or challenges faced by staff during the pandemic and or general infectious outbreaks in the context of the pandemic, while the other 10 were relevant to recommendations or general guidance on how to best support staff, 2 of which were specific to reopening long-term care homes. And I just wanted to state a disclaimer that there was not a critical appraisal done for these sources. CADDIS, in an effort to respond to the immediate research needs during the rapidly evolving pandemic, identified resources relevant to the topic, and most of this information was from the gray literature, which is what we typically mean by literature from non-peer-reviewed journals and may not be considered as high-quality evidence. So next slide. So the literature identified multiple themes and safety concerns of long-term care staff during an infectious outbreak in the context of COVID-19. Many of the safety concerns were related to the proximity of staff to residents during an infectious outbreak in the home. Additional concerns included lack of pandemic preparedness, lack of infrastructure to support infection control protocols. For example, some long-term care homes may not have the space to have a specific isolation room or separate bathrooms for residents. Another concern was shortage of personal protective equipment, especially when the pandemic first hit. Inadequate staffing was heavily emphasized as a concern both before as well as during the pandemic. Delays in testing created anxiety among staff, not knowing which residents may be infected. And there was also confusion stemming from the evolving guidance throughout the pandemic, as we've seen with masks and personal protective equipment and hygiene protocols within the facilities. There was also challenges faced were fulfilling these infection prevention protocols and enforcing social distancing, especially between patients who might not comprehend the reasons for doing so, and between patients and staff given the close proximity of care. And lastly, it was found that lack of information and training related to infectious outbreaks led to increased stress, fear, and concerns, as well as lack of proper adherence to infection prevention control measures. So next slide. So on that note, what was recommended in the evidence was to have adequate education and thorough training on IPC measures related to infectious outbreaks, which was important to staff, to support staff and mitigate infection in the home. Other common recommendations included having adequate PPE or personal protective equipment and resources for staff, mandating the use of appropriate PPE and strict hand hygiene measures among staff, residents, and visitors, and also having active screenings for all staff, residents, and visitors, as well as testing. And long-term care homes must ensure they have adequate access to resources for sufficient screening and testing. Adequate staff to patient ratios was prominently recommended, In a study of California nursing homes, it was found that lower levels of staffing had worse COVID-19 outcomes and higher rates of COVID-19 infection. So multiple literature sources have recommended having adequate staffing, and this allows for regular screening, testing, as well as mitigating concerns and about safety and staff burnout. Another recommendation, next slide, sorry. Another recommendation was having greater coordination with primary care providers. This would assist in alleviating some anxiety felt by staff by ensuring regular recognition of infections and allowing for treatment of more severe cases that may require hospitalization. Another recommendation was access to a knowledgeable infection prevention and control specialist or outbreak response team to assist COVID-19 questions before as well as during an infectious outbreak was important. And we can see with countries such as Australia or Austria that employed these measures early on in their pandemic response and had a good outcome. So policies and programs to support staff was also important, such as financial incentives or full-time work opportunities to limit spread between and within facilities by removing that financial pressure to work in multiple facilities. Policies should also be put in place to promote and enforce sick leave for staff suspected of COVID-19 or exhibiting symptoms. Lastly, it was also recommended that there be transparent communication regarding updates to alleviate anxiety felt by staff, residents, and their families. Directors and managers and policymakers are encouraged to pay attention to the impact of outbreak infections on the psychological well-being of healthcare staff. So next slide. So I just want to highlight an observational study that was specific to reopening of long-term care homes during the pandemic. This study assessed the impact of reopening 26 Dutch nursing homes while following a national guideline as well as local guidelines on visitation protocols. So all nursing homes are generally compliant with the guidelines, and this allowed visitors into the nursing home was unanimously positive for all, with no COVID-19 infections reported within 3 weeks of reopening. However, both visitors and staff as well as residents were worried about the risk of infection. Some staff expressed worries about their own health or the health of their spouse, and also workloads had significantly increased to prepare for these visits. So several nursing homes designated staff or coordinators to be responsible for the organization of the visit, screening visitors, communicating risks to the resident, documenting all information into the patient file, and sometimes supervising these visits to ensure proper protocols are followed. So respondents did report that this was at times stressful and time-consuming. So recommendations were made to leverage digital technology to improve efficiency in charting and make this process more efficient. Next slide, please. So here's a quick true or false. Active screening is a priority when reopening LTC facilities, and true. The answer is true. There we go. So this was not only emphasized in general guidance documents regarding safety and prevention, but also mentioned specifically as a recommendation in guidance documents for reopening. The recommendation includes screening anyone who visits the facility, having temperature checks, questions about symptoms and travel, as well as screening residents daily. It's also recommended that LTC homes have a testing plan before reopening and that they have sufficient supplies to have a baseline test for all staff and residents, and also plan to determine how often testing should occur. It was not required for testing of visitors to occur, but it was highly encouraged for facilities in medium or high positivity districts to do this testing. So next slide. So in summary, there are multiple measures that are essential to support staff during the COVID-19 pandemic. Key support measures included having adequate PPE, staff ratios, IPC training and education, as well as policies and programs to support staff and mitigate risk. Transparent communication and regular monitoring is encouraged and important to support the well-being of long-term care staff and allow them to continue their role in a meaningful way even as visitor restrictions are relaxed. Thank you for listening. And I guess we'll move on to questions.
Actually, I think we'll move on to Dr. Weisenfeld, and then we'll take questions at the end, Deba, if that's okay. So now I'll pass on the presentation to Dr. Weisenfeld, Psychiatrist-in-Chief at Sinai Health, and then we'll take all the questions at the end.
Thank you. Oh, here we go. Thanks very much. I'm going to just do what we do at almost every technology media, the kind of thing, and just confirm that people can hear me by looking at the people who are on the screen. Yes? Excellent. Okay. I don't know if there's a way to start a meeting like that without confirming that, so thank you. Thanks for having me. I'm going to talk a little bit about, I think, some of the things that were already kind of alluded to in I think it's Deba's presentation, and really focus on the idea of sustaining resilience through the pandemic, and I'm glad to take questions from people. I realize it's one of those moments in time where we're not actually just talking about something that happened, but something that's happening and happening to all of us as we're going through it right here together. So what I'll do over the next few minutes is review what we knew and what we know about healthcare worker resilience and coping, and reflect on how COVID-19 is impacting resilience, and also describe some interventions and principles which may support and sustain well-being and coping over time. Okay? I should say also, just in terms of disclosures and disclaimers, I'm trying not to be distracted by some of the tech questions if someone else is having trouble hearing, so I'm going to leave that with the tech support folks. I think fair to say, with anything that's still in progress, we're all learning about what might be better and more and different ways to improve resilience through time, both in long-term care, in hospital settings, schools, et cetera, so I want to acknowledge that. I want to acknowledge for sure that one of the things that I've learned through some of my work trying to support long-term care as well, that we all have different access to different amounts of support, whether it's PPE or psychological PPE or everything in between, and so I want to kind of acknowledge the different privilege that we have in different settings as we go ahead. And I want to say that nothing good comes from comfort zones. I'm really hoping for questions that will help all of us to do better, both in terms of hospitals partnering with long-term care and vice versa. So with that in mind, I just want to acknowledge some colleagues who are also part of some resilience coaching we do here at Sinai, and then really just get to the meat of things. And the reason why I include this particular slide is I think that one of the things that's probably the greatest challenge in terms of thinking about how to support healthcare workers, healthcare staff, and in their resilience is it can feel as if there's so much to do that we can't actually pause and think about how to do it in a kind of psychologically wellness-supported way. And in fact, it is the critical kind of thing that we do, that we must pause and try to figure out how we can help people to sustain ourselves, since we expect this will go on for quite a lot longer. So when we think about what some of the psychological impacts of pandemics and disasters, and if you can believe it, there are sort of subsections in psychiatry, sort of specialization that is actually called disaster psychiatry, which is really about trying to understand the impacts of kind of external threats, kind of brief disasters, including epidemics and pandemics, and thinking about what some of those effects are on people who deliver care, people who provide administrative support in healthcare facilities. And what I'm going to be speaking about is some of the literature around that, and then a little bit about how here at Sinai we've kind of tried to learn from that literature and think about how we have developed some resilient support, hoping it may help for people who are also leading work in their long-term care facilities and in other kind of healthcare leadership roles. The lessons from SARS, which people may remember, about 17-ish years ago, were kind of, I would say, two things at once. We learned from SARS that which was very much a hospital story and not as much of a long-term care story, that for many people they felt quite a lot of stigma, quite a lot of moral distress around the delivery of care during that particular pandemic or epidemic, depending on what language you want to use. But what we also learned was that it doesn't just kind of stop with the experience of the kind of acute phase, but that there are also other phases that kind of follow for, months, weeks, months, and years afterward. And I want to speak about that in a moment. We learned that it was probably one of the earlier times when we thought about the resilience of healthcare workers, because it was a sustained demand on healthcare providers And as people may remember, it was also a time, sadly similar to what's happened in COVID-19, where healthcare workers were not only providing extraordinary care under extraordinary circumstances, but they were also becoming ill themselves, and people were watching their colleagues become sick while they were providing care, and that was something that people hadn't seen in the work of healthcare, in that kind of extreme situation, that extended situation before. And we started thinking about words like resilience, burnout, and wellness, and this idea that we weren't just trying to kind of have the sprint, but rather the marathon, and we had to think about what it was that was happening with healthcare providers. And one of the ways that we can think about the impacts of this kind of extraordinary and novel and sustained distress and need is it can affect people's kind of cognitive and emotional state, affecting their concentration, issues of fear and anxiety. It can affect their physiologic state, sleep deprivation, kind of muscle tension, headaches. These kinds of things can come from the provision of care. And interpersonally, people are also impacted as they try to kind of respond to the challenge and work with their colleagues at a time when they may themselves be feeling quite a lot of fear. And so I want to sort of talk through some of the ways that we have sort of thought about the idea of working through disasters, recognizing that if I would have been making this presentation in April, we could have been talking maybe about preparation, but in fact now we're very much in this kind of active phase of the disaster. And so one of the ways that the literature has helped us to think about how healthcare providers kind of respond in this time of kind of extended pandemic is this idea in the preparation phase, and some of you may feel as if that's sort of still close in mind, that you kind of remember it, that there's this kind of preparation phase that people go through where there's a lot of anticipatory anxiety, a lot of planning, might be a lot of high-level kind of planning, and yet there might also feel as if we're running out of time. I know in our hospital we felt as if we couldn't put together plans fast enough. We were updating pandemic plans that were shaking off the dust. People were feeling a lot of stress, and they were waiting for kind of the actual surge to come their way. And so there's lots of anticipation, lots of worry that we wouldn't be ready. And then there's this active phase that is often talked about in the kind of healthcare worker resilience around pandemics that actually kind of has two parts to it. And I wonder if people, as I slow down my talking a bit to let everyone sort of think and reflect, if people can reflect on which of these feels like they were in or are still in. There's talk of the active phase including the idea of heroics and the surging to solution. It's often a time of increased camaraderie, sense of rising to a challenge. People are kind of seeing things they haven't seen before, but trying to gather together to kind of come up with plans. There can often be, despite this kind of camaraderie, also a sense of disagreement around what we should do first, and so there can be this kind of stress around how to plan. And then also in the active phase, as people are rising to the challenge, there can be this sense of disillusionment and exhaustion. People can feel like they're in full go mode without any more to kind of spare. They can start to neglect their psychological and physical health. They can start to worry, as I know happened in so many long-term care facilities, around how do they make decisions about kind of who might be sent out to acute care, how do they think about caring for palliative care needs, how do they talk to families. And so in the active phase, there can be this kind of heroic feeling and also this sense of exhaustion that's already coming. And we also think about the notion of a recovery phase, which I'll highlight, even though I think that it's an open question as to whether or not some people might have felt in their own jurisdictions whether they had a brief moment of recovery phase, perhaps over the summer between wave 1 and wave 2, depending on where people are, or whether some people haven't even felt like they've gotten to that recovery phase. But I'm noting it because one of the things that we learned from SARS is that even when it was over, it wasn't entirely over, in part because the recovery often is what leads for there to be time for people to reflect. They reflect on what they did and what they didn't do. They reflect on the decisions they made. They start to have the kind of crash biologically of their kind of adrenaline. And all of these kinds of things are important because at whatever time in your own organization or your own community you think you've reached that recovery phase, it's a time not so much to sort of just say, phew, glad it's over, let's just kind of go back to normal, but rather to think about some active steps to take to recognize that there may be quite a lot to debrief. And to think about what to do in terms of people's feedback and ways to come back together, even in the recovery phase where we might just all be so glad to move on to something else. And so I'm happy to go back to that in more detail with some questions, but I think it's worth kind of highlighting that each of those phases has different demands in terms of healthcare providers. Fair to say, as we've been gathering data, and there's been lots of rapid publishing around what's been happening for many people who are healthcare providers. And when I use the term healthcare providers, I want to be also quite clear that at least in our organization, we use that to describe anyone who's doing the work, not just clinicians, which I think is a really important kind of inclusive approach to recognizing that we're all in this together. But some of the common themes that I think have emerged amongst people who are providing care and working in healthcare facilities, including long-term care, are the following. And these won't be a surprise to anyone who's watching or listening, but I think that partly why I'm noting them is because, as you'll see in the next slides to come, that a lot of the work that is actually part of the work of resilience is surfacing some of these themes so we can normalize them, validate them, and help people to feel less alone. One of the things that constantly surprises me in some of the resilience coaching that I try to do is how effective just highlighting to people that their own experience is not the only one, and that the kind of camaraderie that can come from recognizing that there's a shared group experience having these kind of similar thoughts is kind of one of the kind of really important take-home points that any leader, any kind of nurse leader, team leader, director of care can do to try to help their teams. So many people have talked about this idea of the challenge of tolerating uncertainty and fear. In the early stage, it was about how bad was it going to get? Was it going to come to our facility? Were we going to have enough PPE? Were the supply chains going to be okay? What were the guidelines going to change back and forth? And so one of the things that's been kind of almost a signature, I think, in many places of COVID-19 is how rapidly evolving information is and how hard it is to tolerate the uncertainty of what's going to change and how much things may need to change from 1 week, from 1 month to the next. Another kind of key theme that's come from healthcare providers is the degree to which many people who go into healthcare in any number of roles do so with a kind of like hyper-conscientiousness. They're used to learning what they do and doing it properly, and having to continue to master new skills, new ways of doing it, new routines is a stress, especially amongst people who really want to get it right. They don't really want to feel like good enough is good enough. They want it to be perfect. And so that has been, I think, a real stress and strain for many people as they've delivered healthcare during the pandemic. Many people have been stressed by redeployment, whether it's having a different role in one's own organization or moving floors or moving, hats in terms of one's own organization or home care setting, depending on how that setting has operated and depending on whether people have been affected by either COVID-19 directly itself or quarantine or isolation. And so this degree to which people have had to tolerate switching roles so quickly and not having the same amount of time to master it has been a challenge for people. For sure, for all of us, the degree to which the sort of what I call the COVID dominoes, the personal and professional ones, this is, I think, what's been so different in COVID-19 compared to SARS, and it became so evident, particularly I think in April, was as things were getting shut down and restricted across communities, the degree to which people had to master restrictions at home while continuing to work, and figuring out what to do with their kids, with their elderly parents, with their spouses who might also have to work remotely was another strain for healthcare providers that was quite different compared to what many people described as being a very hospital phenomenon where basically the rest of the community was kind of watching the news but wasn't necessarily so impacted. And I think for many people that had kind of almost a dialectic of experiences. On the one hand, it meant that they, unlike maybe some of the people in their friendship or family group who were working remotely, they had to figure out how to continue to work even while everything else was upside down. And the flip side, or maybe the other side, was they also were unexpectedly feeling supported and celebrated with pots and pans and notes of well-wishing in a way that felt, as many people have shared with us, both good and also like its own sort of pressure, as if they were kind of carrying so much for the community that they really weren't used to carrying. We learned a lot about even this term that some of us hadn't even heard before, the notion of moral distress, and that is a big theme, I think, still in long-term care and acute care hospitals, in rehab settings, and community outreach providers, as people had to figure out how to tolerate doing less than what they thought was what they would normally do. I know in long-term care facilities that I was involved in supporting directly, some of that involved doing things like more degrees of medication restraint for patients with dementia and wandering behaviors that they never would have thought of doing for that particular threshold, but had to think of doing to keep people safe and in some sort of restriction and seclusion. For other people, it was about not being able to facilitate even tablets and phone calls to families while families were calling all the time and feeling quite stressed themselves and realizing that you just couldn't take as many calls while you were also donning and doffing. And so I think the moral distress for many people was quite strong, including some of the, I would say, between wave 1 and wave 2, which may be meaningful depending on all the different jurisdictions that people are listening in from, the kind of in-between phase where people had some time to reflect, and then moving back into wave 2 and new restrictions as people are reflecting on visitor policies and who can come in and who can't, that distress around recognizing how much people want and need their families, and also how worried you might be in terms of letting families and friends come in who might be asymptomatic carriers of COVID, and then set off the dominoes of more people being infected. And I think the moral distress term, as in some ways it can seem as if it applies to so much of what people went through at every level. There are administrative staff who told me how badly they would feel about not returning a family's phone call as quickly as they would have before the pandemic. There's nurses who told me they felt badly they couldn't spend as much time with the patient. There's people who felt distress around the sharpness of their tone with colleagues. So I think every piece of what people had to do and have had to continue to do in order to try their best to do the most important thing, even while they were kind of almost making their good enough slimmer and slimmer and slimmer in terms of what was acceptable, I think have been some common themes of the COVID-19 experience. And there isn't enough time to give justice to, I think, how much health and racial inequities also were kind of key themes of what we're all probably noticing around COVID-19, whether it's about the experience of personal support workers who are a largely racialized community of workers in the COVID-19 pandemic, whether it's about the disparities around who was getting COVID-19. But I think that was weighing quite heavily, I think, on people and continues to do so. And then I think that in some ways the last few are almost the ones that we were expecting from the beginning in terms of what some of the impacts would be on staff. The degree to which almost any stress or strain, especially one this big in the workplace, is going to amplify earlier traumas and vulnerabilities. Anyone who's gone through any other kind of situations which have been distressing, whether it's an actual diagnosed mental health disorder like depression or anxiety, or whether it's going to be at other experiences that made people feel even more vulnerable. But I think any kind of extra external threat for sure was amplifying distress in people as they were trying to rise to this challenge. And I think the last I would say, which in some ways is also the kind of meta message, people felt lonely. People probably still feel lonely. I know I'm in a community where we're still largely restricted, and as a healthcare provider myself, I'm probably overly restricting myself, as people often are as healthcare providers. So still spending time mostly with your own family, not really going out, not going to restaurants, not being able to do fun things, feeling more lonely, I think has been a big theme. And I think a bit similar to how many of our nursing colleagues felt during SARS, the degree of stigma perhaps around family and friends who maybe would prefer not to include healthcare providers in their bubble or their circle or their particular grouping, in part because they either worry about infection towards you or possibly, even seeing you as high risk if you're a healthcare provider in long-term care or in any kind of healthcare setting. So all of these, and I'm sure people could come up with their own list as well, have been emerging as some of the themes that are really the weights on healthcare providers in long-term care, in acute care, in rehab settings, in community outreach settings. And I think they're worth surfacing, as I said before, in large part because we can't deal with things unless we name them, we label them, and we help people to feel less alone as they do this important work. So as we flip from thinking about, okay, that's the whole weight of all the problems, all the challenges, I think it's probably useful, especially for the purpose of this kind of presentation, to highlight what are the kind of key principles, and many of you are doing this already because it's November, it's not May, that are kind of considered leading practices around responding during this active phase. I'll go through them. I'm sorry for seeming like I'm sort of reading on these kinds of presentations, but since we're not all together, it's kind of a way to make sure everybody can hear and hear it in a different way. One of the most important things, which again is hard in COVID because of the distance that we're all supposed to be maintaining to keep healthy and safe, is visible leadership. And one of the things that I've said in some other presentations of this sort is that COVID has made it such that having an open door policy, whether you're a director of care or you're a leader or you're a nurse leader, doesn't really seem like it fits very much unless people can actually get to your door. And so visible leadership is an important principle of responding to support resilience for a few reasons. One, to make sure that people know that you're in it with them. Two, so that you can see what it is that people are actually coping with. The only way to do that is to kind of go to the Gemba, as people have heard, said in terms of improvement literature, go show respect, ask why. And so visible leadership I think of as being both about being seen and also about seeing what people are dealing with in terms of what challenges there may be that they're bringing to you. Communication, of course, is an important aspect of leadership during these active phases. And I think of communication in COVID as being almost two or three things at once. It's about communicating frequently so people kind of have this bidirectional communication, and having a communication strategy that absolutely acknowledges that you expect directions to change. I think one of the ways in which leaders probably sometimes got into and get into trouble in this evolving novel pandemic is imagining that anything that we say on a Monday is necessarily going to still be true on a Friday when it comes to the restrictions, when it comes to policies. And I think often really, really good communicators in COVID have been good at saying, here's what I know right now, here's why we're doing it, and here's how I'm going to be accountable for letting you know when things change. And when things change, I'll tell you why they've changed. And I think people who've been able to speak in that way have often been able to help not only with camaraderie, but actually with resilience, because people understand where information is coming from. Of course, people need to have consistent access to physical safety to be resilient, PPE, food, and sleep. And the reason why I, as a psychiatrist, mention that is because in our work as kind of resilience coaches here in our hospital and beyond, one of the things we've had to say over and over again is that resilience coaching and attention to wellness is not a replacement for Maslow's hierarchy, right? We all need to have access to PPE and safety. Otherwise, it doesn't matter how much wellness support you provide to people if you can't actually keep them safe, which I know we all know, and yet sometimes I think that, it's important to make sure that we do what I describe, which is sort of we need empathy and IPAC. We need, to have, kind of sensitivity to each other, as well as making sure that people have infection control that makes them feel supported. The other, I think, key principle, responding during the active phase is helping people to manage moral distress, either by, finding ways to provide psychological support to patients and families, or to help people take pride and satisfaction in their work, even in these unusual times. And the last two, I would say, and I've been doing the sort of second last one this whole time, is normalizing psychological responses. One of the things we say over and over again in some of the work we do around resilience coaching is people do generally know how to cope. It is actually the external threat that's making them feel not like themselves. Their actual responses are, by and large, absolutely normal responses to extraordinary stress. One of the things that we can all do as leaders and colleagues of people who are working in all care settings is to acknowledge that we're all feeling this kind of normal psychological response in this extraordinary time. And the last I would say is that even while we're normalizing, we also want to pay attention to people who may need something extra. And some people who may need something extra might be people who have already come to this pandemic with other vulnerabilities. Some people might for the first time be experiencing, kind of the illness of depression or anxiety. And so we want to think about delivering formal psychological care in stepped ways. One way of thinking about that is this figure from a really good paper by the British Psychological Society around healthcare resilience, which really just is a visual to think about what are the basic things we're all doing. We want to provide basic needs and physical resources. For people who need a bit more, we provide a bit more information about how you can do some self-assessment about whether or not you're kind of becoming perhaps depressed or anxious. And then some psychological first aid is giving people maybe some tips around mindfulness, sleep hygiene, that kind of thing. And then an actual psychiatric or psychological intervention for people for whom the first three isn't sufficient to maintain their resilience in the face of this kind of stress. And some people will still say, no thanks, we are too busy. But I think that what I wanted to kind of highlight is some ways that people have tried to approach this. There are lots of interventions and approaches that are being trialed across the world during this challenge. Some of the main things, just to kind of name them, because I want to make sure there's time for questions so I don't monopolize too much more of this time together. A lot of what can help with staff is just some psychological education around these normal responses, whether it's taking one of these slides and using them or doing your own version of it. But I think the key thing is letting people know it's normal to be stressed, it's normal to be having these reactions, and that what people need is a kind of common opportunity to reflect on it and to get support around this kind of normal response and some validation. You've heard me talk about the term resilience coaching, which is a term that we've kind of coined here in our institution. And really the reason why we talk about it that way is we want to be clear that that the same as you might have an athlete who needs like a coach to keep their head in the game, we see supporting resilience as being about recognizing people know what they're doing, they just need a little bit extra support through some of these interventions. Battle buddies is a term that's being used, or COVID buddies is a term that's been used in a lot of the literature, and really has to do with the idea that one of the strategies that you can use is thinking about asking everybody to kind of partner up in your organization and be accountable to each other to check in. How are you doing? Do you need any support on a regular basis? I have one who's a colleague in another hospital. Many of us have found that just having someone where we've agreed that we're going to be in touch to sort of check on how each other is doing, is an important part of supporting resilience, and especially over this long period of time. Skill building can help as well as an intervention, whether it's thinking about options for mindfulness, meditation. Behavioral activation is just a fancy way for saying keeping people active and busy outside of their workplace so they don't just go home and spend their time kind of just taking a break, but rather thinking of exercise and other hobbies and activities that they can do. And really kind of thinking about applying kind of traditional psychotherapeutic principles to teams by highlighting, kind of cognitive approaches, behavioral approaches, and really sort of tackling threats to resilience over time. I can say more about that, but I want to leave time for questions. So the last thing I'll say is that what I found and what many of us have found in our coaching in the last sort of 8 months, and when we work with others who are doing similar work both in acute care and in long-term care, is that what many people really kind of benefit from is kind of just-in-time dissemination of tools, whether it's a quick kind of slide that people can have that kind of highlights something, or a video that you can point people to. One of the things that happens when you can point people to something relatively quickly is it normalizes things right away, because you're basically saying this has been prepared for people who have the exact same challenge, and so it's already ready for you. And then it's also something people can engage with in their own time. So what I mean by tool dissemination is you can think about this is a really simple one, which when I first saw it I thought was almost too simple, but it's what we call a resilience alphabet, and so it's a slide that I often send out and have taped on my door for people to see when they think about what's something you can do right now that might give you some greater support. Is it that you can talk to a friend? Is it that you can pick M for moving? Is it you can think K for thinking about kindness? I think sometimes these things can seem almost too simplistic, and yet it's often the simple things that work. And so I have a copy of this resilience alphabet. You can't see it, right, taped to my computer, so that when I'm working on doing some one-to-one or group coaching, I can use it as a tool. And having sent it out to people, it's actually one of the things that people ask me for over and over and over again. And just putting it on your door, if you're a director of care or a team leader, also signifies to your staff that you're thinking about resilience. So it's worth always thinking about anything you can do that symbolizes that we're not just trying to do all of the other important physical care things for our residents or patients, we're also trying to look after ourselves. And some other things that we've produced, which I'm happy to share further, but so many other organizations have produced videos that talk about coping with stress, podcasts. All of these kinds of resources can help be kind of easy things to just sort of give to people, so that if they can't gather otherwise and it's not appropriate because of your staffing or your physical setup to do so, that thinking about tools that you can give out can be very helpful as a thing that can also be a delivery from you to someone else. I think if you're like me, you sometimes feel like, what could I possibly give that's going to be enough to undo the no fare of COVID? And sometimes even these small things can help make you feel good about how you can help your staff. I can hear myself taking a breath, and I can see lots of questions about this, so I'm going to just advance one more just to say that I'm happy for feedback, for questions. including feedback about all that we're getting wrong in terms of those of us on the psychological side of things, because certainly we're in it together. So if there's feedback about what we can all be doing better, I will take a breath and leave it to Tanya to moderate.
All right, great. So maybe we'll start with you, Dr. Weisenfeld, since we just wrapped up your presentation, and then we'll then bring Deba back on for the list of questions that have also popped in for her. So thank you for this great conversation today. There's actually a lot of questions about having access to your resources. So if you're happy to share, lots of people in particular are interested in the alphabet.
I know. I'll say also, the thing I love about the alphabet, first of all, the alphabet is made by someone else, and so I'm happy to share it. The acknowledgement is right on there. In fact, I often use it as a chance to demonstrate humor, because what I love about the alphabet is that that X is xylophone and Z is zebra, even in the resilience alphabet. So I use it to kind of make the point that even in the resilience alphabet, X is still xylophone. Happy to share all of these. I'll send it, Tanya, to you and the organizers, especially because there's no reason for people to kind of reinvent the wheel if other people have things that are kind of crowdsourceable. My pleasure.
Great. There's also some questions. I know you've presented some interventions and approaches, but are there other strategies that long-term care homes can use to support staff with the psychological impacts of COVID, and how do they support their staff to remain resilient through these times?
Yeah, so it's a great question. So I wanted to share, I'll be quickish but tell you my experience. So one of the things that I had the privilege of being involved in and still involved in is supporting some homes here locally. And so I've also taken feedback from those colleagues who certainly know much more than I do about long-term care, even though as a geriatric psychiatrist, obviously I do some work there. I will say that one of the things that I tried to do, and at least received some positive feedback about, is I think that if you're doing clinical rounding, whatever way it works, and I don't want to make any presumptions about how every other group works, I do think that trying to create some time, some space in any meeting or approach where people just finish by at least saying, how is everybody doing? Is there anything else anybody needs? Because I think one of the greatest risks in all of this rushing that comes in healthcare, I mean, I don't know about everybody else, we were all rushing beforehand. Healthcare workers are used to rushing. And then we went on kind of hyperspeed as we were all trying to get through this. And I think that whoever will sort of feel most able to be the one who kind of slows everything down a bit and kind of acknowledges that the extra 5 minutes to say, how do people feel about that? You know, is there anything else anybody needs? Someone who will either be designated to do that or they will do that as a matter of course is sort of worth its weight in gold. And that's the feedback I've had from our long-term care colleagues. And the other thing, as I would say, is I think there's a tendency for all of us, whether you call it a huddle or a business meeting or whatever the heck it's called in everybody's environment, to see if you can find a way to have an agenda-free meeting where the agenda is about checking in. Because again, I think with so much pressure, we all, I think, are vulnerable to thinking that it's a waste of time to take time, and yet it's in fact the rushing that makes everybody feel as if we're running out of time, when in fact, like 5 minutes to take a breath, 5 minutes to let people, you know, kind of share their moral distress, 5 minutes to let people say, holy heck, this feels hard, and I'm really sad that I can't do more for this family. Even if it leads to tears, even if it leads to people needing to regroup, what I've seen, and again, it's not a novel observation, is that it lets people feel more together, and it lets people feel as if there's still going to be a team when this is all over. And what I just did a debrief with a home that I work with around how people felt sort of prickly with one another and how they were trying to find ways to practice saying, like, that feels prickly, I don't think it's about me, but like, could you please stop being so prickly? I think that people being able to kind of acknowledge, like, my tone is not for you, it's just coming from how I feel, and then working on improving that really helps a lot. It sort of reminds me of the literature around the surgical pause, around safety, are you familiar with? But it's about taking a few minutes for each other. Yeah.
Great. So Deba, now over to you. We've had lots of questions about ratios and adequate staffing, which I am sure you're not surprised about. So in your presentations on having adequate staffing, have you come across any guidance with respect to what the best ratios are for each of the different categories? I'm sure she anticipated this question coming through, so nurses, attendants, recreation staff, so on.
Yeah, so within our search, which and the literature document that we've compiled, the synopsis, which will be shared, I believe, by CFHI after this meeting, we identified a report on nurse staffing from Nova Scotia, and so within that document, it was stated that based on best available evidence, the adequate staffing ratio would be 4 hours per 4 hours of direct nursing and personal support care per day per resident. So as you know, like all long-term care staff will have different numbers of residents and staff, so they recommend 4 hours of direct nursing and personal support care per day per resident. And I also want to state that the synopsis that we created, the evidence found within it is up till July 31st of 2020, and as you know, COVID-19 is a rapidly evolving situation, so guidance may have changed since then.
And have you seen any specific best practices for secure units in long-term care? Any specific guidance protocols around ratios?
The guidance was pretty general to long-term care. I didn't really see mentions of secure units. And would you be able to clarify what is meant by secure unit? Is that just a long-term care home with no infections, or?
No, my understanding would be, so say there's a unit for people living with dementia in that specific unit and in that specific home, and usually they're on a separate unit and they're more secured so that there's limited access for patients who wander and so on.
Okay.
They may have more high needs. Yeah.
Okay, thank you.
So just changing subjects a little bit, I'm going to pose the next question to Dr. Weisenfeld. So there was some comments around the same moral distress and dilemmas for essential care partners. And so how do we support them? I know your presentation mostly focused on the healthcare workers, but they're also experiencing the same distress, deciding whether they come in to visit their loved one or not in long-term care. So any particular advice to support them?
Yeah, so I thought you were going to ask a slightly different question. I was already nodding in that terrible way that I already anticipated the end. Because I was thinking, I don't want to forget to also mention the moral distress I think that exists for leaders. I think one of the things that's hard for leaders as well is if you're developing practices and policies that you realize will be hard for your frontline staff to deliver, which you maybe aren't delivering exactly yourself, which can feel also a challenge. I think. I hope I haven't, although I feel a sense of engagement with this crew, I hope I haven't, there's for everything. I mean, I do think one of the challenges of this in general, and forgive me, just use a phrase that has been a bit wrecked by the presidential election, but like sometimes it is what it is. I mean, sometimes, I think that what we are sort of trying to say to healthcare, to care partners, is that this is a really, really crummy time where, there is no great solution, and yet we all have to think about what we can live with. And so what I think can sometimes help with care partners, if I understand the question, Tanya, that you're moderating, is I think the question is how do we help people who are wondering, like, should I come in and possibly, kind of, is the question like, should I come in and asymptomatically possibly be spreading something? Is that part of the question, do you think?
Or should I come in knowing or not there's an outbreak in the home, but I'm an essential care partner for my loved one living in long-term care and I want to be there for them and I'm a provider of care as well. And so just reconciling whether or not they should come in, whether they're part of that high-risk group as well for COVID-19.
So yeah, no, I think I understood it. So I mean, I think that it's worth reflecting with people on the fact that, they have to think about what they can live with in terms of the pros and cons of something. I think that it's also worth them reflecting on the fact that, like, nothing in life, of course, is certain. And, I think sometimes people may have more regret, overdoing versus not doing. And, that we all, kind of are wishing that this was different. I mean, sometimes what I say is look, there's the core behaviors of the washing your hands and the wearing the mask and the keeping the distance, and then there's recognizing if things go wrong, we blame COVID, we don't blame each other. And I think sometimes that language, as much as it might seem kind of sloganistic, is really critical. It's critical, I think, with frontline workers around, look, we do all these things, we do the distance, we follow the best science, and if still there's an outbreak or if still there's a bad thing that happens, we recognize that we blame COVID. We don't blame each other. And I think sometimes that can at least help feel like it's at least a kind of solidarity mantra. And I think that it can apply also in families, where we kind of, I think one of the things that a lot of families were going through probably post the initial opening up as people were deciding about circles and bubbles and things like that, is how much we could have almost a new contract with each other. Like, what are you doing? What am I doing? Okay, if you agree not to go to indoor restaurants and I agree not to indoor restaurants, then maybe we can be together. So I think, again, we try to have trust, and then we agree that like these are extraordinarily stressful times, and that if we did nothing, then we would be physically safe, but perhaps psychologically and mentally vulnerable. And if we did too much what I call COVID cavalier, we would have a lot of regrets. And so finding some place in the middle where we can live with it, recognizing that, if I think as a physician, how many times somebody would say to me, and even more so during COVID, what would you do if it was your mom, right? What would you do if it was your brother? And I try to say two things. I say, look, I can tell you what I would do, but I also need to tell you how I think about these things, because I might think of them very differently than you do. But I think we blame COVID, we try our best, and then we blame COVID.
And so last question to you, Deba. Have you seen in the research that you've done any negative impact from limiting staff to one particular long-term care home? So I guess the sense of like cohorting staff so that they're not working in multiple high-risk environments. Have you seen any negative impacts of that practice, knowing that it's been recommended for a reason?
I can't say that in the search that we did, we didn't find negative impacts, mostly because it was mostly just general guidance that was identified. And so the reason being for limiting to one care home was to prevent spread, but also was recommended that the care homes, if they are doing that, to have financial incentives like having full-time work opportunities, or I guess increase in pay so that workers don't have that economic or financial pressure or vulnerability to have to work in multiple homes. And the reason being that there is the risk of increased infection moving between different homes. And I just wanted to answer another question in terms of, I just wanted to clarify with the Dutch study, I should clarify that the workload that was increased was administrative. It wasn't that family or made it harder for the staff to work, or it was more so that the staff identified that they had more paperwork to do in order to ensure the safe visitation of family caregivers into the home. So I just wanted to clarify that.
Thank you for clarifying. So as you can see, thank you very much to both of you. As you can see, this is actually a very timely topic, and most of the teams working with us in our program are actually focused on people in the workforce. So thank you both for taking the time today to share both the research and the practice around this. And if we have any unanswered questions, we will do our best to filter them back so that we get answers for everybody. So thank you very much, Dr. Weisenfeld and Deba. So just on to our final slides. So thank you, everyone. And just a reminder that we are still accepting applications into our Long-Term Care Plus program. We simply ask that you complete a self-assessment to identify your improvement objectives. We encourage you to do this with family, care partners, and residents to ensure that their perspective is also taken into account into this work, and that we will continue also to learn and share via our virtual offerings. So our next session is November 19th, where we have a huddle, so an ongoing discussion about people in the workforce, and December 3rd as well. And then our next virtual learning series is December 7th, entitled Pandemic Response and Surge Capacity, where we'll feature the experience of South Lake Regional Hospital. So on that note, if you have any questions, feel free to email our long-term care inbox, and we'll be happy to get back to you and answer all your questions. And we thank you to our presenters again for this great discussion. As you can see, we probably could have had another hour. And now I will leave you with the polling questions. So thank you, everyone, and have a good afternoon.
This concludes today's webinar. Thank you, everyone. You may now disconnect.